Hello, my name is David Murdoch, and I'm here with my colleague Susan Beasel, and we are representing content that we shared at the OR Business Managers Conference at the beginning of this month. I lead our staffing and productivity practice and have been in healthcare consulting since 1993, with the last 15 or so years focused on staffing and productivity. Susan?
So I'm Susan Beasel. I am a nurse. I work with Novia Strategies as a director in their surgery practice. Been with Novia for 6 years, and formally for 40 years have been managing surgical services.
Thanks, Susan. A little bit more about Novia. We are a team of clinical, operational, financial experts, and we work with hospitals to help them improve operations, quality, and financial strength. The session today, we're going to cover some learning objectives that we had for the session that we presented at the OR Business Managers Conference. Talk a little bit about why the content that we're reviewing today, which is a review of different approaches to determining staffing in the operating room. We're going to summarize those approaches. We're going to discuss pros and cons of both approaches, and then go through a little bit about how to reconcile the approaches, and then have some implications and takeaways. There is actually a takeaway tool that we developed to help reconcile some of the options. And then Susan is going to share with us, once we have those targets, what's next. The learning objectives that we had were we wanted to share a little bit more about how to match surgical supply with the demand. So we're matching the resources to the demand. As you take a look at external benchmarks, a little bit around how to appropriately select peers, review the pros and cons of the various approaches, and how to partner effectively and successfully with physicians and other clinicians in developing your surgical staffing model. Many of the session attendees really felt that they had been in meetings like we are reflecting here on slide 6, where we have one individual that is thinking she and her department are able to hit their budget targets related to dollars. So why does it really matter how they spend those dollars? So that person was hitting their targets financially and was less concerned about hitting her productivity targets. Then you have a provider there to the right of her that's thinking that he has more complex cases and is going to need more staff for that. The person in the middle is more of the finance guy or decision support guy that is more focused on performance to benchmarks, and his thoughts are that the perioperative services weren't at top quartile yet related to productivity, and the CEO's objectives were to get all the departments there this fiscal year. Then we have another perioperative manager that's thinking that she's having difficulty responding to the desire to have what she feels is an inexhaustible amount of resources for surgeons, and the cocktail hour surgeries are increasing. And then a final perioperative services manager that has reviewed the ARN guidelines, and according to those guidelines and how she's interpreted them, their staffing is lean, so she's wondering why they're talking about productivity benchmarks. So it's interesting. Susan and I met years ago when we weren't at Novia, and we both were working for different clients and were different organizations, and we're at the same client. And Susan was in an interim manager role, and I was sort of that finance guy that was talking productivity targets with her. So we actually had a meeting like this several years ago, and actually ended up at Novia working together to help organizations interpret these myriad of perceptions. The approaches that we're going to review today really are two: the traditional productivity measurements and approach to using those, and then the ARN staffing guidelines that were published by the ARN organization. So on the traditional productivity measures, there's really using either worked hours, or you can also, some organizations will use paid hours per case, or the same worked hours, paid hours per 100 minutes of OR time. And related to the ARN staffing guidelines, they use an average staff per case and then use a coverage-based model to determine staffing. So we're going to actually review each of these and talk about the benefits and some of the considerations for each of them. The first one we're going to drill into is the productivity measurement approach. As many people in the audience were familiar with when we presented this session, and I'm sure that people that are listening are as well, that in traditional productivity-based resource planning, you have a unit of service or workload volume. You have the target related to that volume, and you use both of those to determine what your resources are needed. So in the examples, you can see that Hospital 1 is budgeting 725,222 OR minutes for next fiscal year. They're using a top quartile benchmark of 10.58 worked hours per 100 OR minutes, and do the math, do the multiplication, and then divide that by the number of FTEs, a number of hours per FTE. And in example 1, it's a relatively small OR. You have 36.89 worked FTEs because that's the target that we were using. It was based on worked hours per minute. Hospital 2, they are using cases, and they've budgeted 35,000 cases. They're using paid hours per case, so the 11.19 paid hours per case. Do the multiplication, divide by hours per FTE, and then they have a budgeted number of 188.29 paid FTEs. So this is just the math behind the traditional approach to productivity measurement. Some of the advantages of that approach are the fact that if you are using benchmarks, that the benchmarks are designed to be inclusive of all of the worked and paid hours. So you'll have your direct and indirect hours in there as well as overhead positions. You can also use peers in your benchmarking review, peers that are relevant to your organization, that have similar case mix, that have similar approaches to staffing. And you do have flexible metric options. We often will recommend that organizations use minutes. There are times where cases, in the instance where they might have very quick cases, cases might be a better, more reflective measure, but oftentimes we are recommending the use of minutes. When using traditional productivity measurements, you also have the advantage of having very specific and standard definitions and calculations so that you know that you're having a fair comparison because you've obeyed the rules of normalization and assigning standard departments, if again you're using a benchmarking system. Now, the challenges related to traditional productivity measures, the first one is around skill mix. So if you are just using the hours per unit of service as your metric without any considerations for skill mix, then that could present a problem where you might have heavier skill mix that's oriented towards more expensive resources. So balancing just the hours with the cost is how you would address that challenge. Another challenge is in any benchmarking-based approach, you can really get caught up in analysis paralysis, where you are trying to fine-tune that peer selection criteria to the nth degree, and so sometimes that can be overwhelming. Sometimes you might miss out on some better performers if you are too selective with that peer selection criteria. It may also not factor in the impact of your highly specialized cases, or if you have strategic growth initiatives and are expecting an uptick in volume, the traditional approach may not account for that if you don't have that factored into the math that you use to calculate your resources. On slide 11, it's just an example of how varied the use of those hours per case can be, or hours per minute can be. And it's just a reflection of the skill mix that we're using. Actually, in this instance, it's data from our ActionOI database that we use from IBM now. And so no really analysis needed here. We just wanted to reflect the fact that you should, once you get your hours per the service target, you should also have some considerations with how you divide up those hours. Next, we're going to go into the ARN-based approach to determining resources in the OR. Here, it's more of a coverage-based approach. So you determine how many rooms you have, what the hours of operation for that room, for each room are, and then just use a average average staff per case to determine what your staffing needs are there. So it's definitely more of a approach that's based on the coverage needed. This was sourced from the 2014 AORN position statement on perioperative safe staffing and on-call practices. So one of my colleagues actually used that position statement and converted that into a spreadsheet that enables our clients and people interested, and again, it was a giveaway at the conference, to use this approach as well as a benchmarking-based approach to contrast and compare the staffing that you would get, using the AORN standard versus a benchmarking-based approach. The advantages of the AORN guidelines, the fact that it is AORN, you have the credibility of the professional society. As you'll see, if you do download the spreadsheet, it is flexible enough to try and account for some level of acuity. The average resources per case is something that you could calculate based on your case mix and your assumptions related to the number of resources per case type. Since you are using a coverage-based approach with AORN, it does enable you to factor in operational and business factors. So if you, again, have to cover certain hours in the OR, you're able to factor that in, whereas a productivity-based approach would require you to have the volume to support being open those hours. So that is a little different between the two approaches. The AORN guidelines can be adapted to use RN to tech ratio to further build out the staffing requirements. The challenges related to the AORN guidelines, the fact that the way that you would determine the average staff per case is more of a subjective approach versus a severely scientific approach. And there's ways around that if you can have visibility into what cases require additional staff and have that supported by another professional society that would help address that challenge. Another challenge is it does require assumptions for the indirect and overhead positions. Because it is a coverage-based approach, you have to actually put in assumptions when you fill out the model around how much indirect time and how much overhead time you would need to build out the rest of the department. And like the previous approach, for productivity approach, it still may not factor in the impact of any strategic growth initiatives. On slide 15, we just have a couple of quotes here that help crystallize the challenge of having a one-sided approach to resource planning. So Machiavelli said, "Whosoever desires constant success must change his or her conduct with the times." It really means that if you're using historical performance without the benefit of any external benchmarks, you may be out of line with the times, as Machiavelli said. The quote from founding father George Washington, "We must consult our means rather than our wishes." And that means that even though, as we saw in that first slide, we had a provider that wanted to have more resources because of more complex cases. And then we had a person that was referencing cocktail hour surgeries. All of that is good if you can afford to pay for it, but you do have to have those staffing planning efforts be based on what you can afford. The next two slides are really tangential to the discussion, but it was interesting research that we did in preparation for the conference. And so what we're doing here is showing the hours worked per 100 operating room minutes, and that's this traditional productivity measure that's used in Action OI. And one of the peer selection criteria was around having a improvement project in place, or a cross-functional process improvement team in place in the OR. And so it just shows that the green is all hospitals that are in the database that reported. That gold color, they have an active interdepartment CQI team in place. And then the blue organizations indicated that they did not have an active interdepartment CQI team in place. So this really just shows that regardless of having that CQI team in place, the efficacy of that team really drove whether or not the productivity was going to be improved or not. The second slide is the same cut in terms of peers, but what we are bringing into this, instead of just the productivity-based measures, which we saw before, this is really a total expense, and it talks a little bit more, shows a little bit more evidence that having that interdepartment CQI team, their focus of those teams are likely on total cost, because you can see through the analysis that they are the organizations that do have that CQI team tend to perform better. So just some interesting research that we had related as we were doing the research for the presentation. So how do you reconcile those different approaches? So just to recap, we have that productivity-based approach where we're looking at having benchmarks to compare ourselves to. There's also the traditional productivity measurement where we didn't have the benchmarks, but we're using historical data to help set targets, and then using the ARN staffing guidelines. So considerations for the productivity approach with benchmarks are making sure that your peers are meaningful but not exact. Know that your orientation and training are expected to be in work hour benchmarks. We know that as you move into productivity measurement, those hours are sometimes excluded, but for benchmarking purposes, they are expected to be in there. You want to make use of those detailed definitions and instructions on how to normalize the data and how to select standard departments. You want to make sure that all your volumes are accounted for. I know that this presentation is mostly about the main OR suite, but one of the challenges that we've seen in perioperative services is around PACU workload, where you may not always have the workload reflected. So making sure that those hours or minutes in the PACU are all reflected. And finally, with that approach, even though you're going to normalize some non-standard FTEs and hours out for benchmarking, when you're setting productivity targets, then you need to actually factor those back in. So that's a step that we always do when we work with organizations with our implementation projects, is setting those targets based on benchmarks, but making sure that they account for anything that wasn't to be included in the benchmark. Just the thing to note around using historical data, so that second row, we actually had a recent client that it was mandated to all departments that they use a paid hour per unit of service target, and that it wasn't adjusted. So what that did, it actually built in a level of expected improvement. As staff gained tenure and had more time off, then you'd have to actually manage that paid hour. So it was an interesting approach to having an automatic level of improvement built into the department. Finally, using the ARN staffing guidelines, the fact that when you choose that number of staff per case, it can be somewhat subjective. So supporting that by as much data as possible is highly recommended. And there's very little guidance around the support that you're going to add to those direct care hours of coverage that are needed. And so making sure that that has some, that managers and directors and leaders have visibility into what goes into that overhead and really understands that. Slide 19 is an example of the worksheet that was developed, and it allows you to load in the ARN guideline-based approach. It allows you to take a look at some national benchmarks, and I'll just call out the note that's sort of in the middle of the screen that the benchmarks that we include in the tool are extremely high level. National benchmarks have not made use of any peer selection. And so it's recommended that this is used for high-level checks and that any more specific review of staffing resources would require, if you're going to use the benchmarks, the fact that you would need to have more selectivity related to the peers. So once you have either been given those FTE targets or have calculated them, really what comes next? Because the planning of the resources really is just the tip of the iceberg in the starting. So Susan's going to walk us through what comes next.
So this objective addresses partnering effectively and successfully with physicians in developing your surgical staffing model. So to partner effectively with surgeons, we're seeing a lot in the literature about physician engagement, and it really takes the courage to ask the surgeons what they want, and then to be creative and realistic in answering what's in it for them. So to the right of this slide, you see what we're hearing from our clients, that surgeons want a voice and they want to be heard. They want to be more productive. We commonly hear that if they have an 8-hour block, they are able to complete 4 hours of surgery and they sit and wait for the other 4 hours. They believe that they're 50% productive. And unfortunately, we find that an awful lot in the data. They want to decrease waste. Time is wasted to them. They want to reduce process variability, so they want it to occur the same way every time. And they'd like us to be innovative and creative, but simplify the delivery models. Next. What are some of the key traits of a high-performing perioperative services? Governance. It's led by a perioperative body that manages department resources. I'm going to give you some more detail about governance in the upcoming slides. But this is very, very different from your standard operating room committee. This is an administrative committee with a single agenda and really looks at the business strategy for the department and establishes some rigor, specifically rules and regulations about scheduling. And when you talk about rules and regulations for scheduling, you're getting into your hours of operation and establishing the expectation of what available resources would be. Case scheduling. The cases are scheduled using historical data. So that means moving away from the physician telling you how long the procedure is going to take to actually using your automated scheduling system to calculate averages for more accurate scheduling and planning. Operating room availability. The hours of operation in staff rooms have to match the demand. So again, that cocktail hour surgery that David mentioned earlier, we are seeing, and I believe that our audience is also seeing, that after clinic surgery at 5 o'clock in the evening. And there's a peak in that. Your operating room utilization. Is your prime time utilization 75 to 85%? And that aligns with your block utilization. is block utilization greater than 75% and with minimum blocks of 8 hours. You want to get the surgeon there and keep the surgeon there all day. We all know that every time you change surgeons and you change specialties, it adds to downtime between cases. First case on time starts. Do 95% of your cases start on time? And if they don't, what are the root causes of that and how can you correct it? Subsequent case start time. This should average less than 45 minutes per OR per 8-hour day. So if your first cases aren't starting on time, your subsequent cases are not starting on time. And that metric is measured cumulatively throughout the day. Patient out to patient in. That's nursing's turnover time. Is it 25 minutes or less? Have you embedded parallel processes? Close to cut, is it less than 50 minutes? Cancellations can be very disruptive. Are they less than 3% within 24 hours? And patient and chart readiness. Are your patients ready? Are they cleared and prepared for surgery? And do you know that they are at least 48 hours prior to that date? So this is more about physician governance. We refer to it at Novia as an operating room executive committee. This is an operational steering committee for perioperative services. Often implementing an operating room executive committee takes some outside consulting assistance. This is significant in a cultural shift in the department. The committee is chartered by administration to have full control over periop services. It's led by clinically active surgeons and anesthesiologists and includes administrative and nursing representatives. The goals of this group are to clearly define the governance, establish a clearly defined governance structure, engaging physicians, nursing and administration, and operations management and strategic planning, with an overall arching goal of creating a patient-first culture. Their deliverables, they determine the department metrics. They charter work teams to improve poorly performing metrics and develop that business strategy. The benefits of this is a credible forum for decision-making with strong clinical representation. There's a single agenda back to management, operations management, and strategic planning. And it overall improves access and throughput and provides opportunity for growth. This is the group that begins their work by determining the metrics of the department. What are the important indicators for efficiency for you to measure? So if your surgeons are saying that they're only 50% productive, you need to measure that. Are cases starting on time? Where is the waste in your system? Where is the rework in your system? And one of the key things that we see in many of our clients is that because the hospital or the department hasn't established some rigor around rules and regulations, how cases are scheduled, how patients are prepared, what time does the day start, that there's a lot of inefficiencies, and each surgeon has developed their own process. So this group is looking at standardization, eliminating waste, implementing parallel processes, and how to become more effective and efficient in establishing a patient-first culture. Efficiency performance indicators. So we touched on this 2 slides ago. These are some of the key metrics that we would recommend that all operating rooms are measuring. And the definitions are provided. So your suite utilization, you're including turnover time in that calculation and dividing it over the regularly staffed time. First case on time starts. Those are regularly scheduled, so those are elective cases that begin at or before the scheduled start time. And what does start time mean in your organization? we would suggest that it's patient in the room. If you're falling short of getting patient in the room, making cut time, your start time, is going to be an even longer initiative for you to correct. Subsequent case start time. So that's the mean tardiness of start times throughout the day. Case cancellation rate. We look at cases that are canceled within 24 hours, and we look at cancellations that are avoidable. Case duration scheduling accuracy, that's using the historical case data and measuring that for 8 hours of OR time. Patient out to patient in, the minutes from one patient leaving the room to the next patient going in. And we measure that for the same surgeon on the same day, as well as close to cut. We look at from the close of that the first surgery to the cut of the second procedure, and then throughout the day for the same surgeon on the same day. And we're spending a lot of time on PACU length of stay, which quite often is a throughput initiative that has to be implemented to get those patients into an inpatient bed out of the phase 1 PACU. The phase 1 PACU staffing standard, for the most part, for most patients, is one nurse to two patients until the patient meets discharge criteria. Some of our findings are that patients will reach discharge criteria and for a variety of reasons may not be moved out of the recovery room. Unfortunately, that staffing ratio isn't being changed either, which adds additional costs to your recovery room staffing. Now I'm going to walk you through some tactics and some strategies related to managing your productivity and standardizing your processes, taking some of that variability out. This one is associated with centralized scheduling and patient access process. If you have multiple areas where physicians' offices are scheduling patients for access, this initiative in centralizing scheduling can actually reduce the variability. It centralizes all surgical and invasive procedure requests and case posting and manages the daily schedules in a single area. It's a single vehicle to schedule surgical cases with a standardized methodology, again, taking that variability out and in multiple different processes that each surgeon has invented themselves to get into your surgical services. It links scheduling with other perioperative processes. So you want, if your patients are going to be ready on time and your charts are going to be complete, it links them with pre-admission testing. It also can link them with case management for inpatients, patient access and bed placement to reduce that PACU length of stay, pre-registration and insurance authorization. And what are the instrument and supply resources you're going to need? What about that radiology and the limitation of radiology? How many techs can radiology provide you in the operating room? So the sooner you know about things, the better planning you can do. And having all of this information come in through a single process for all of your surgical units and even your out of OR areas can help you to better manage resources and have that patient ready and know that you have insurance authorization and decreases the amount of rework on the front end in the patient access department as well. Block scheduling, near and dear to every surgeon's heart. What we're seeing in the literature with block scheduling is a vertical scheduling model with 8, 10, and 12-hour shifts. So no longer are we seeing 2-hour blocks, 3-hour blocks, 4-hour blocks, that morning block that then there's a break in between, and the afternoon surgeon who never gets started on time because the surgeon in the morning ran over. We're seeing utilization thresholds of 75 to 85% for surgeons with blocks. They're measured monthly and adjusted quarterly. Assign blocks to surgeons versus specialties. When you assign blocks to a surgeon or a specialty, there's an embedded accountability associated with it. When you assign block to a specialty, you have to ask yourself, who's going to be accountable? You set automatic release times by specialty. We are still working with clients who have 24 and 48-hour release times for their blocks. Operationally, that's a significant issue in planning the OR schedule, planning the staffing requirements, as well as the other resource requirements, radiology, SPD, instruments, supplies. Set voluntary release times. So you require that surgeons with blocks, if they're going to be away, they're going to be at a conference, on vacation, that they're giving you 3 to 4 weeks notice so that you can release that time to other physicians. You want to reserve 20% for first come, first serve. And you need to consistently enforce the rules. So again, back to the governance structure, there's rules, there's rigor, and they need to be enforced. Block scheduling is a caveat. Block scheduling is for your predictable book of business. Every surgeon is not going to have a block. Not every surgeon brings you the amount of business that they need to bring to even have a block. Then the next thing, surgeon and specialty teams. This is a carrot. This is something that surgeons love. But not every surgeon is going to have a specific team, and sometimes not even a specialty team. This strategy has select surgeons lead dedicated perioperative teams. These are your high volume surgeons that consistently have a high rate of starting on time, excellent block utilization. They agree to meet the efficiency requirements. They streamline the process. They ensure that their patients are ready. They arrive prior to the case start time, and they remain in the suite. Coupled with surgeon-specific teams are staffed by dependable, efficient nurses. And the staff selection criteria is that they are willing to tailor their work schedules around the surgeon block. So if you have a surgeon that works 2 days a week and has a 12-hour block, he needs a team that works those 2 days a week in the 12-hour block. This eliminates a lot of intraprocedural disruptions with changing teams out and relief. So, in implementing this can be a challenge. One of the ways that we've had some experience doing this successfully is to say to the surgeon, 80% of the time you'll see the same people across the table. It would be almost impossible for you to promise that 100% of the time they would have the same team. But if you could meet this 80% of the time, imagine how much better their day would be. They're matched with nursing personnel who like working with them, who know their technique, who can anticipate what's going to happen, and the cases go a lot smoother and are more efficient. Perioperative patient navigation. This tactic works very well in a GI suite. It also works very well for those fast-moving cataract patients that are coming in. This is a twist on pre-admission testing, not necessarily for your lower acuity patients, because that, almost all patients have some comorbidities, but your very low-risk surgery. So in GI, it's a fabulous strategy. Our experience is that GI patients normally are not coming through pre-admission testing services. They receive a robocall from the gastroenterologist's office saying, we've scheduled your screening colonoscopy for a certain date at a certain time. We're going to send you the prep information, and a lot of these gastroenterology practices are not seeing patients prior to the procedure day. One of my recent experiences with a client is that the gastroenterologists were booking double the volume that they could accommodate and expecting 50% of that volume to arrive. Very disruptive for the department. Patients were all being told to show up at the hospital at 6:30 in the morning. So if 20 patients were scheduled and 10 all arrived at 6:30, then there was even some patient bickering going on in the waiting area about who got there first and who was going to be second. So we began this process with peri-op nurse navigation at the time of scheduling to plan the patient course. And we have a patient navigator who is assigned to do this full time. And that person ensures that the patient assessment, either by telephone or on site, is complete. They contact the patient ahead of time to review the case time, the start time, what are the prep requirements, anything special that we should know about the patient, is the chart complete. Then they check the charts for appropriate and complete diagnostics and consults. They're able to manage it up to anesthesia if there's an identified issue. They confirm the patient day of surgery instructions, NPO requirements, and ensure that outpatients understand the need for a ride. And then on the day of the procedure, these nurses are actually facilitating the admission throughput and facilitating the schedule with the GI unit and in the outpatient surgery center for the cataract patients, so that there's no break in the surgeon's work and physician's work. The patients are ready, they're admitted, and our commitment in implementing this was that we would have 2 patients in the room, 2 patients ready, and 2 patients on deck to go in. The outcome of this initiative is that 99% of patients that are called by the patient navigator and given instruction come to the hospital and have their procedure complete. And they don't all come at 6:30 anymore. They come when they're told, and the procedures are completed. Physicians are really happy. There's been an 8% growth in volume in the departments that we've implemented this in recently in one of our clients. Proactive schedule management. This is something that came to me after many years as a director of perioperative services. And one day I actually I had to take a step back and said, is the schedule managing my department, or am I managing the schedule? And I discovered that the schedule and my surgeon customers were really running the department, and that there was some proactive initiatives that I could do to plan. So essentially what I'm saying to you is, if the cases are on your books and they're elective and you know about them, why do we have surprises on the day of surgery? This is a group huddle that occurs daily. It includes representatives from pre-admission testing, same day, the ORs, anesthesia, PACU, central services, and supply chain to proactively plan the next day's schedule. Their objectives are listed here, ensuring that first and subsequent cases aren't going to be delayed, resolving conflicts. They can resequence cases for improved throughput. They eliminate and reduce gaps in the schedule, so they're able to move cases up, ensure appropriateness of the planned surgical time, again, ensuring that that historical time is being used, and they communicate any required schedule changes back to the surgeon. So this is a telephone call. It's a very positive call. We want your cases to start on time tomorrow. We notice that your second patient is completely prepared. We have all the resources lined up. Your first patient is going to require an INR in the morning, or an A-line, or a block. and it's going to delay the patient going into the room. So can we do your second case first and move that first case into order for the second? And surgeons appreciate it. They want to start on time, and we've been very successful in implementing this tactic and helping to plan for tomorrow's surgery. So what's in it for the surgeons? A governance model that transforms the culture and really embeds some accountability, a dashboard where they can track key performance indicators, and that OR director now has a dashboard where he or she can track the indicators, and it's shared with the medical staff, and there's a cascading message. Successes are celebrated. New initiatives are chartered by the operating room executive committee. There's a leaner OR with decreased waste and improved efficiency. And there's innovative care models, surgeon-specific teams, patient navigators. What can we do better to make the surgical experience a better experience for our surgeons and for our patients?
Thank you, Susan. And should you have any questions about the take-home tool that should be included in a link around the content, please feel free to contact us. Bye.